taken MCQs and I have organized them chapter wise, and in the end I have kept around 10 MCQs which are image based, right? So 40 MCQs chapter wise and 10 image based questions from orthopedics. So starting with the first chapter, that is anatomy of bone and fracture healing, and this is just a basic of some anatomy also. So type of collagen which is found in cartilage. Now here uh, type 1, which is, you can remember it like bone, so B1 bone, so that is how you can remember type 1. Type 2 is the one which is predominantly present in cartilage. Type 2 is the one which is predominantly in cartilage. Type 3 is in the blood vessels, and type 4 you can remember floor. So type 4 or floor, and floor is actually the basement membrane. Clear? So this is how you can remember type of collagen present in different structures. Type 1 in bone, type 2 in cartilage. So here the answer will come out to be type 2. Right? So this is the answer here. Just to summarize, type 1 in bone, skin, tendon, dentin, type 2 in cartilage, type 3 especially in blood vessels, and type 4 in the basement membrane, and type 5 is penta, or you can remember it for placenta. So these are the different types of collagen. Now moving forward to one question which is about complication or some problem related to union, right? So if a fracture definition is quite the question its definition is quite the question itself speaks for the answer. When the fracture is taking more time for union, obviously you will call it delayed union. Now taking the options, non-union, right? So here the answer is delayed union. Now non-union, now non means no. So if you want to define non-union, we can say that the process of union has stopped, right? And there is no fracture union. The process has stopped before the proper union of the fracture. Such a status will be known as non-union. Then another word is malunion. Now the word mal means bad, or in relation to this we can use the word wrong. So it means the union has occurred, but it has occurred in a wrong position. Clear? So here we can say the union has occurred in a wrong position. That is known as malunion. Then delayed union we have already discussed, like process is delayed, process of union is delayed, but it's undergoing, it hadn't stopped, it is taking a little bit more time, but the process is continued. And exuberant means too much of callus, and here it is usually seen in cases of head injury. So the callus is too much, so that is known as exuberant union or exuberant callus, right? So anyway, that's not a problem for us. ABC are really a little bit problematic in certain cases, and like if there is non-union, obviously we have to do something to get union at the fracture side. So what we can do? We can do open reduction plus internal fixation plus we need to put cancellous bone graft so as to promote the chances of union, right? So we have to open up the fracture side, we have to refresh the fracture ends, we need to do internal fixation, a rigid internal fixation, and then we need to put some cancellous bony chips usually taken from iliac crest. So that is the treatment of non-union. Similarly, for delayed union, we need to promote the process, so we can simply put cancellous bone. Okay? So this is in short. Now malunion, at some places it is acceptable. Say like if it is clavicle fracture, mostly it malunites. So in that case, there is no functional disability, so let it be, right? So at some places it is acceptable, but at some places if we feel that it's really not acceptable, then we have to redo the surgery with internal fixation and bone grafting, cancellous bone graft. Clear? So this is in relation to problems, complications with union. Then moving forward to another chapter, that is treatment of fractures, and here there is one surgical principle which says that the destructive forces are converted into compressive forces. Now destructive means, when we say destructive, it means the forces which tends to take the fracture fragments apart, right? So pulls fragments apart, and we know that if there is distraction of the fracture site, the fracture will never unite. The fracture fragments, they have to be in close contact, then only the fracture will unite. So destructive forces, they tend to minimize the chances of union. And compressive, when we write compressive, it means the fragments, they are brought closer to each other. So fragments are brought closer. So what is that surgical technique which converts the destructive forces into compressive forces? And that surgical technique is known as tension band wiring. Clear? So this is the tension band wiring, where if the implant is put in such a manner that the destructive forces, they convert into compressive forces, they bring the fragment closure, and that increases the chances of union, right? So one of the example is tension band wiring, and every student should know at least two examples where we do tension band wiring. One is of course fracture of patella, and another is fracture of olecranon. Right? These are the two common examples which every student should know. So keeping this concept in mind, we can say that the answer is olecranon process here. So this is the tension band wiring surgical principle. Destructive forces are converted into compressive forces. And in terms of olecranon process fracture, suppose if this is fractured segment, something is, we know that there is the insertion of triceps muscle here. This is the triceps muscle, right? So if we do tension band wiring here, the moment triceps tries to take away the fragment, in fact it will bring the fragments closure, and it will cause compression, and therefore it will promote the chances of union. So this is tension band wiring. So again, if someone asks you which fracture is managed by tension band wiring, I think now it will be very easy for you to answer the question. You can say this is fracture scala or fracture olecranon. Then moving forward to a very important chapter, that is complications of fracture, and rarely there is an exam which does not include a question from this important segment. So a patient is having a history of road traffic accident. Now he is having respiratory distress. His CO2 is 60%, is not improving despite oxygen therapy. He is also having CNS depression, and there are other multiple blunt injuries. The chest X-ray is normal, and therefore it rules out any lung pathology. The chest X-ray is normal, it means there is no lung pathology. Now, if we just take up the different points which are given in the stem of the question, one of the important thing is that multiple injuries. Apart from this, patient is having respiratory distress, CO2 is low, and there is one more clue which is given here. There is CNS involved, right? So this all goes in favor of the entity, that is fat, right? So there is fat embolism, and one more classical feature which is usually noticed is rash, which can be seen over trunk or conjunctiva. So if you see this kind of picture, it is very easy to answer it as a case of fat embolism. And now, what is the source of this fat? It actually goes from the medullary cavity, and medullary cavity of long bones like femur. So whenever you see a case of fracture shaft of femur, always keep the possibility of fat embolism in mind, right? And therefore we say don't unnecessarily move the patient. So this is a classical presentation of fat embolism. There is a respiratory problem, it can be tachypnea. Then there is CNS involvement, and more importantly, cutaneous finding in the form of rash. Yeah, so this is classically for fat embolism. So here the answer will come out to be fat embolism. And since the chest X-ray is normal, so you can clearly rule out any pneumothorax, because that will show radiolucency, right? That will show radiolucency. Then similarly, if there is pleural effusion, that should show you radio opacity. And hydropneumothorax, you will have both the features, and in between the two there will be a straight line. So these are not possibilities here. Classically, this is fat embolism. Then moving forward to another question. Now here, an elderly patient was operated, and the surgery which was done was THR, total hip, and usually we do it for osteoarthritis of the hip. And after 5 days he presented with breathlessness. Now what can be the problem here? See, here are few important points. One is elderly patient, second is long duration surgery, right? Now these 2 points, they increase the chances of deep venous thrombosis. Yeah? So they increase the chances of deep venous thrombosis, and this can lead to pulmonary thromboembolism. Yeah? And pulmonary thromboembolism, it presents as tachypnea or dyspnea, right? So this is how the, the, the entire stem can be framed into the answer. So here the answer will come out to be pulmonary thromboembolism, which is because of deep venous thrombosis. And elderly state, long duration surgery, and we can add one more point here, that is prolonged bedridden state. So all these factors, they increase the chances of DVT, and DVT can lead to development of pulmonary thromboembolism, where the most common symptom is dyspnea, and the most common sign is tachypnea. Right? So this is how you can just summarize this entire topic. DVT leading to pulmonary thromboembolism. Then an intern was working in a busy casualty. Now, which of the cases of upper limb fractures will he show to his seniors immediately? It means which of the condition is should be at the top priority for discussion with the senior doctors. So here we have few options. Now let us see one by one. Fracture with reduced capillary. Now if there is reduced capillary refill, it means there is reduced vascularity. Right? And if there is reduced vascularity, it indicates there is some injury to blood vessel. So because of fracture, there is injury to the nearby vessel. And if this is not addressed timely, it can lead to ischemia or even gangrene of the distal part. So this should be at the top priority. Whenever you see a case with any indication of a vascular injury, it should be at the top of the priority, because we have to restore the blood supply as early as possible, otherwise the tissue might go into. If there is laceration, it is not that important, simply you need to dress it, and if there is a fracture, just give a splintage for the time being. So that's not that at the priority. Similarly, intra-articular fracture have to be addressed by are to be managed by open reduction internal station, but they are not at the priority. And fracture with wrist drop, again it suggests radial nerve injury. It demands some attention, but not that much as it is needed for the vascular injury, right? So fracture with reduced capillary refill or any indication of vascular injury should always be at the top of priority in terms of management, because a delay can lead to irreversible loss of blood supply to the distal part, and that can even result in gangrene. That should be at the top of priority list. Then next question, a patient was on long-term steroid therapy. Now he presented with pain in both the hip joints. Now what can be the condition here? Now one of the thing which is mentioned specifically, that the patient was on long-term steroid therapy, maybe for any condition, and here there is no history of injury, right? So there is no history of trauma. So straight away we can just rule out anything which is related to the traumatic options. And most importantly here, one of the complications which you should remember in terms of long-term steroid therapy is the possibility of development of avascular necrosis. avascular necrosis. I think the term is self-explanatory. A means absent, vascular is blood supply, and necrosis is the death of the tissue, right? So what happens? There is avascular necrosis, especially of the head of femur. So this can also be a complication of prolonged steroid therapy, because usually what we do, whenever we teach AVN, avascular necrosis, we always talk in terms of fractures like fracture neck of femur or fracture talus. But AVN can also develop as a result of prolonged steroid therapy. Please remember that. Now, coming to AVN as a complication of fracture, and the question is about which part of scaphoid is most susceptible to develop AVN. And to answer this, we should know the pattern of the blood supply of scaphoid, then only we can answer it very nicely. So, tubercle, proximal third, middle third, distal third. Now, if we take the scaphoid, here is radius, right? So, this here it is articulating with the radius, and here the second row of carpal bone. Clear? So, this is the anatomy of scaphoid. Now, what happens? Scaphoid has got a very unique pattern of arterial supply. So, what happens? The artery goes like this, and the branch it comes like this. Clear? So, what I mean to say, that the arterial supply is distal to proximal, because this part is distal and this is proximal. So the arterial supply travels like this, right? So something like this. Okay? So the artery is traveling from distal to proximal. Now what happens? Suppose if there is a fracture in this area, it can damage this artery. Once the artery is damaged, so this part, it is the proximal part, it will be devoid of the arterial blood flow, and therefore it will undergo necrosis. So if someone asks you which part of scaphoid is most susceptible to AVN, your answer will be it is proximal, right? And why proximal third? This we already discussed, because of the unique pattern of the blood flow, or the arterial blood flow, which travels from distal to proximal. So if there is any fracture, especially involving the waist region, it can disrupt the arterial blood flow, and therefore the proximal part of the scaphoid will undergo avascular. Please remember this, and this is the thing which you need to remember for AVN of scaphoid, right? And commonly the fracture in such cases occurs through the waist. There is no possibility of AVN in tubercle, middle third or distal third. It is only the proximal part. It is only the proximal part which is highly susceptible for AVN, right? Similarly, in cases of say fracture neck of femur, it is the head of femur which has will undergo AVN. Again, the pattern of blood flow is like that only, because the arteries, they are traveling through the neck to the head. So if there is any fracture in the neck region, the arterial blood flow to the head will be compromised, and there is possibility of AVN, the head of, right? So please remember this. In scaphoid, it is proximal 1/3. In femur, it is head of femur. And similarly, in talus fracture, neck of talus, there can be avian of the body of. So these are the three important examples from which the questions are usually framed, and you should know the fracture, you should know the the location of the fracture and the area which is prone to develop avian, and the basic concept remains the same. The arterial blood flow is in such a manner that if it is disrupted, the area which is undergoing necrosis will be devoid of the arterial blood flow. Clear? So this is in short about avian. So if someone asks you which is not a site of avian, I think all of you can answer easily. It is the head of radius. There is no concept of arterial blood flow which is compromised because of fracture. So head of femur, body of talus, and proximal. Right? And you should know the area which will undergo necrosis, and you should also know the site of the fracture. So head of femur will undergo avian if there is fracture through the neck of femur. Body of talus will undergo avian if there is fracture through the neck of talus. And proximal pole of scaphoid will undergo avian if there is fracture through the waist of. Right? So please remember that. Now moving forward to injuries in children. Now this is a very important segment because we know that there is a growth plate in the bone in children's, and at times it can get injured, and that might lead to complications, especially related to limb length. So here there is a case about like a 3-year-old child has a history of fall from height, and when X-ray was done, there was no bony abnormality. But after 2 years, the child presented with a calcaneovalgus deformity. So what could be the cause? Now this is the problem with the physeal injuries, the growth plate injuries. They cannot be seen on the X-ray, especially if there is if it is not associated with any fracture. So maybe in this case there is compression of the growth plate, especially on the lateral side, so that the medial side continued to grow, and that resulted in calcaneovalgus deformity. Right? So it is because of the tibial physeal plate injury. This is injury of growth plate. So what happens, suppose if this is the tibia like this, so what might happen, like this lateral side of the lower tibial physis might have been injured, but the medial side continued to grow normally, and as a result of this there is a valgus deformity around the ankle. Right? So this is physeal injuries, very important topic in pediatric fractures. This is physeal injuries, and at times if they go unnoticed, this really causes deformities later on, and which is the case in this given question. Now next question, a child is lifted by maid and holding the wrist of child. After this, the child started crying and was not moving his elbow. What could have occurred here? Now here the child has lifted, the maid has lifted the child through the wrist. It means there is an axial pull. And whenever there is axial pull, there is possibility that the radial head might slip out of annular ligament. Here, so it might slip out of annular ligament, and this condition is known as pulled elbow. And since it is associated with sometimes associated with maids, so we also call it nursemaid elbow, because they usually take care of the child, and if they pull the child in such a manner holding the wrist, then there is possibility of pulled elbow. So this is the case here. So this is a case of pulled elbow. Right? So axial pull along the forearm or the wrist, it can lead to pulled elbow. Now, a 1-year-old child has multiple fractures, and these are in various stages of healing. Now, what can be the condition here? Now, see, if there are multiple fractures and which are in different stages of healing, it means there are different episodes of injury, and this is classically seen with battered baby. This is battered baby syndrome. There will be bruises, there will be telltale signs of injury, and as evident by different fractures and different stages of healing. So that shows that there were multiple episodes of injury being done to the child. So this is battered baby, various stages of healing. Then moving forward to peripheral nerve injuries, and here one question is about an alcoholic who slept at the night, keeping his head over the arm, and next morning when he woke up, he found that radial nerve was paralyzed. Now this is which kind of injury? Now what had happened here, there was compression of the radial nerve because the fellow slept in such a posture that the head was resting on the arm. So there is compression of the radial nerve, and this resulted in paralysis of the radial nerve, and the patient have developed wrist drop. Now, what kind of injury is this? So whenever we discuss nerve injuries, we discuss in terms of two facts: anatomy, and second is of course physiology of nerve, and third point, based on these two, we can discuss about the outcome. Now what happens in neuropraxia? The anatomy is okay, there is no injury, there is no structural injury to the structure of the nerve, but yes, physiology have gone. Since there is no anatomical damage, we can expect 100%. So this is the case here. So this is a classical case of neuropraxia, where because of compression the nerve has stopped working, but this is temporary. Eventually the nerve will start working again, so 100% recovery. So prognosis is good for neuropraxia. Then there is another variety, axonot masses. Now here there is cut axons. So the axons are damaged, right? But now what will happen? There is, you can say 50-50. There might be recovery, there might not. So this is 50-50% chances of recovery. And the worst type is the neurot masses, where the entire nerve is cut into two halves. So here the chances of recovery almost 0%. So these are the different types of injury patterns depending on the structural damage to the nerve. If there is no structural damage, only there is physiological cessation of activity, eventually the nerve will recover, 100% recovery. Axonot masses, only the axon is damaged, we have 50 chances of recovery. But in neurot masses, since the nerve is cut into two parts, so spontaneous recovery is not possible, right? So this is neuropraxia, which is very commonly seen in clinical practice, and this is one of the examples where we can say this is neuropraxia kind of injury. Another example of neuropraxia is you can say if there is a application of a tight cast, and this is especially in cases of, say, if you are applying a above knee cast, and if you haven't padded the knee area properly, there is possibility of compression of the common peroneal nerve, and you will see later on that the patient developed foot drop. So this is also a kind of neuropraxia injury. So this is also an example of neuropraxia. This is neuropraxia. And for neurotmesis, suppose you are giving incision at some place, and if the nerve is very superficial, it can be cut. So that is neurotmesis. You have simply cut the nerve into two parts. So this is different terms related to peripheral nerve injuries. Then moving forward to another question that is about nerves and their possibility of injuries, especially in relation to fracture of humerus, and we have to exclude the nerve which is no way anatomically related to humerus. So there is no chances of injury if there is any fracture of the humerus. So I think everyone knows that radial nerve passes through the spiral groove of the humerus posteriorly from the medial to the lateral side after coming out from the posterior cord of the brachial plexus. So there are chances of injury if there is fracture shaft humerus. So fracture shaft of humerus can injure radial nerve. Ulnar nerve passes behind the medial epicondyle. Therefore, if there is any fracture of medial epicondyle, there is possibility of injury to the ulnar nerve. So fracture medial, right? Axillary nerve, it is related to the surgical neck of humerus. And therefore, if there is any fracture of the surgical neck of humerus, there is possibility of injury to the axillary nerve. So these are few nerves which are very commonly injured in fractures of humerus. Musculocutaneous nerve is no way involved in fractures of the humerus. And there is one more fracture which can involve a nerve of humerus, that is fracture supracondylar. Fracture supracondylar region can injure median nerve, or more specifically the anterior interosseous. So as far as the humerus is concerned, these are the few nerves which are at risk of being injured, and therefore you will see there are plenty of questions from this segment. So one should be very well versed with all these concepts, and you will get to have at least one question from this segment. Yeah. Now, foot drop is because of injury to which nerve? Foot drop means patient is unable to dorsiflex the foot. So if we say foot drop, patient is unable to dorsiflex the foot. So the patient is unable to dorsiflex the foot. Now it means which group muscles are paralyzed? These are dorsiflexors foot. Dorsiflexors are paralyzed, and dorsiflexors are supplied by deep peroneal nerve, right? And deep peroneal nerve is a branch of common peroneal nerve, right? So this is how you should take this question, and in most of the MCQs you will have common peroneal nerve as the answer, and that is because isolated injury of deep peroneal nerve is not that common. But clinically we see cases of common peroneal nerve injury because this is associated with fracture of neck of fibula. So if there is any fracture of neck or fibula, always check for dorsiflexion of the foot and document whether there is injury to common peroneal nerve or not. That's very important. Okay, so foot drop, this is because of fracture, commonly clinically seen with fracture neck or fibula, as it can injure common peroneal. Right. Then next question, motorcyclist has road traffic accident and have some injury in the around the wrist, and later on he developed hypothenar atrophy. Now hypothenar area is below the little finger. Right? So that rounded prominence below the little finger is the hypothenar area, and this area is composed of muscles which are all supplied by ulnar nerve. So these are supplied by ulnar nerve, and therefore if there is atrophy of this hypothenar area, you can say this is injury. This is because of injury to the ulnar nerve. Right? Thenar area, which is below the thumb, this is all territory of median nerve. So this is all supplied by median nerve. Right? So hypothenar, ulnar nerve gone, thenar area, median nerve gone. Apart from this, there might be other findings as well. There will be hollowing of space between the metacarpals. There will be, there can be partial clawing also, right? So all that thing. So this is the moment you see the word hypothenar atrophy, go on to ulnar nerve. Then a patient presented with tingling sensation in the thumb, index and middle finger. Thumb, index and middle finger, and this tingling sensation can be aggravated by palmar flexing the wrist for around 1 minute. Now, what is the diagnosis here? So, for this we need to know the anatomy, that lateral 3.5 fingers, especially on the polar side, it receives innervation from median nerve. Here, lateral 3.5, and when I say lateral 3.5, it includes thumb, index finger, middle finger, and lateral half of the ring finger. Lateral half ring finger. Clear? So this is 3.5. And what about the 1.5? Like if I write here, medial half of ring finger and the little finger. This all is territory of, this is what you write as the medial 1.5. Again, volar side, this is all territory of ulnar. So as far as the volar side of the hand is concerned, lateral 3.5 gets innervation or gets cutaneous supply from median nerve, and medial 1.5 gets sensory innervation from ulnar nerve. So in this particular case, the tingling sensation is specifically defined in the area of distribution of median nerve. So we can presume that there is some compression neuropathy of median nerve. Now, when the palmar flexion of the wrist is done for 1 minute, this compression is even more aggravated, right? So this will, increase the pressure over the median nerve, and therefore the symptoms will also be aggravated. And this particular test is known as the Phelan test. The Phelan test, you palmar flex the wrist for around 1 minute, and you try to aggravate or you try to increase the compression over the median nerve, If this aggravates the symptom, then we are very sure that this is compression neuropathy of median nerve, and that entity is known as carpal tunnel. Carpal tunnel syndrome is compression neuropathy of median nerve, not to be confused with cubital tunnel syndrome, which is the compression neuropathy of ulnar nerve, right? And you can remember U of cubital, you can remember U of cubital with U of ulnar nerve. So that way you can remember, because many times students they just mix up like what is carpal tunnel, what is cubital tunnel. Please don't mix up. It's a very important segment, and most of the time we have a question from carpal tunnel, right? So carpal tunnel syndrome, compression neuropathy of median nerve at the wrist, and if you know the anatomy of the carpal tunnel, there is a, it's actually a osteoaponeurotic tunnel. Lower side there are carpal bones. On the top there is a flexor retinaculum, and through this tunnel there is passage of median nerve, and therefore it is highly at risk of being compressed here. The condition is carpal tunnel. Myalgia paresthetica, this is lateral cutaneous nerve of thigh compression in the inguinal region, and impingement syndrome is not a compression neuropathy entity at all. So this is classical for carpal tunnel. Then moving forward, which of the fracture of the upper limb does not require any specific treatment? Simply you need to give a cuff and collar sling, and that's enough. So for fracture ulna, we need to do, most of the time, if it is undisplaced, we will give a POP cast, but if it is displaced, we need to do open reduction and internal, right? So this is done for displaced fractures, especially in adults. Undisplaced, you can simply give a POP cast. For humerus, again, in adults usually we go for open reduction and internal fixation with plate and screws, or what we can do close reduction and then internal fixation with intramedullary nail, right, with interlocking screws, but this has to be done under the arm. So this is your choice what you want to do. So there are two options. And for scapula, we need not do anything, just give a cuff and collar sling for 2 to 3 weeks, since it is surrounded by all around by muscles, and muscles, they provide good amount of blood supply, and it is a rule that if there is good amount of blood supply around the fracture site, it will really heal well, right? And therefore we see that most of the metaphyseal fractures like fracture Colles or intertrochanteric fracture, they unite very nicely. The only thing as a doctor we need to do is to give proper alignment, otherwise malunion is very at those places. But in scapula we don't worry about that. And for radius, again it depends, like if it is radial shaft, we can go for ORIF as we do for ulna in cases of displaced fractures in adults. So for scapula, there is no specific treatment, just simple immobilization, that's sufficient. Then moving forward to perilunate dislocation. Now this is one very important entity, because there is one entity that is lunate dislocation and another entity that is perilunate dislocation. So to understand this, we have to understand the anatomy around the wrist joint. So if looking at this image, this is lower end of radius. Then this is the lunate bone here. Then distal to lunate is the capitate. The capitate bone. And the capitate bone, it articulates with the metacarpal. This is the metacarpal. This is the metacarpal. This is capitate. This is lunate, and this is of course the radial distal part. Now, normally, if we see, all of them are in an alignment. When we use the word perilunate, peri means surrounding. So here, what happens? The radius and the lunate bone, they are still in alignment. So if we look here, this is the lunate bone and this is the radius. So we can see the radius and the lunate bone are still in alignment, but distal to that, the capitate and the metacarpals along with that, everything moves backward, means posteriorly or dorsally. So in perilunate, what is happening? Radius, lunate are still in alignment, but distal to lunate, capitate, metacarpal, phalanges, everything moves backward. So that is known as perilunate dislocation. Right? So in perilunate dislocation, what will happen? There is posterior dislocation of the capitate along with the remaining bones of the hand. So everything distal to lunate will dislocate posteriorly. That is perilunate. Now, what will happen in lunate dislocation? This is also very important. Now, in lunate dislocation, isolated lunate will dislocate anteriorly, and the remaining structures, that is radius, capitate, metacarpals, and the remaining hand, all of them will remain at their right. So in lunate dislocation, if we see, only the lunate is moving and it is moving anteriorly. This is posterior. Clear? So this is the differentiation between lunate dislocation and perilunate dislocation. And again, a very important segment, many times the question has been asked. So again, we can see here the radius, then capitate and the metacarpals, they are still in their alignment. Okay? So you can see they are still in the alignment, but the capitate, but the lunate, it has moved anteriorly. So this is the lunate. So if the lunate is moving anteriorly, leaving rest of the bones in their original alignment, that is lunate dislocation. In case of perilunate dislocation, the lunate is in its original position, but the part of the hand distal to that posteriorly. So in perilunate, there is posterior dislocation of the capitate along with the remaining bones. Okay? So this is how you should remember lunate and perilunate. Next question. So a patient presented with pain swelling around the shoulder area following a fall on outstretched hand. So this is what we usually call push injury. And this is the mechanism for many injuries of the upper limbs, push injury. And now on X-ray, we can clearly see there is a fracture of clavicle. Now we have to answer, like, what is the usual site, what is the most common site of fracture clavicle? Now, I think most of you must be knowing that it is the junction of the medial 2/3 with lateral 1/3. So this is the most common site of fracture, and this is one X-ray I kept just to document this. So this is the medial third, and this is the lateral. Yeah, so you can see this is medial 2/3, the lateral 1/3, and this is the usual site of fracture in most of the cases. Now, what is the reason why? This is because if you look at the anatomy of the clavicle, on one side it is tubular and on the lateral side it is flat. So that transition from the tubular bone to a flat bone is the area where it becomes susceptible for fracture. That's why it usually fractures at the junction of medial 2/3 with lateral 1/3. And in the same picture, we can also take this opportunity to discuss the displacements. You see, the medial fragment is going upward and the lateral fragment is going downward. The medial fragment is going upward because of pull of sternocleidomastoid muscle, and the lateral fragment usually sink downward under effect of gravity or by the pull of depth. So that's why we see these typical displacements, medial fragment going upward, lateral fragment coming downward. So this is the usual case. Now, in some MCQs, we don't have this option, junction of medial two-third and lateral one. Now, in such cases, what to answer? So this is obviously our first choice, but if it is not given in the examination, then you can think of lateral one, right? So this is the sequence of the frequency of the fracture. Junction of medial two-third, lateral one-third is the most common, followed by fractures of the lateral one-third of clavicle. And this is one fracture which can be managed very easily with a figure of 8 brace or bandage. And the commonest complication, most common complication is malunion. But we don't worry about this complication because the function of clavicle is to transmit the weight of upper limb to the trunk through the ligaments, and since it has no role in any movement of the shoulder joint, so it's of no functional disability to the this fracture clavicle. And moving forward, epileptic patient. There is a epileptic fit, and after that, he has pain in the shoulder region. And when the upper limb was examined, it was adducted and internally rotated, and movements could not be performed. So, one of the important thing is epileptic fit. Post this, there is no movements at shoulder joint here, joint, and classically the attitude is adduction, internal rotation. So this is very suggestive of posterior shoulder. So this is posterior dislocation of, right, and it's not that common injury. There are few conditions which predisposes to posterior shoulder dislocation. One is of course epileptic fit, or sometimes if there is electrocution. Yeah. So the moment you find a case history which is starting with the word epileptic fit or electrocution, keep the possibility of posterior shoulder dislocation in your mind. Right? So these are two important things. Obviously, adduction and internal rotation predisposes for backward movement of the head of the humerus from the glenoid fossa. So this is a classical case of posterior joint. Then the patient presented again with there is a Fuchs injury and there is a dinner fork deformity. In Fuchs injury, dinner fork deformity, I think a very easy question everyone can answer. The Colles fracture. So there is a Colles fracture which gives rise to a dinner fork deformity, and here the distal fragment actually migrates dorsally, therefore giving rise to this. And there is another fracture that is known as reverse Colles fracture, that is the Smith's fracture. It gives rise to garden page deformity. And why we call it reverse Colles? Because the movement of the distal fragment is in opposite direction to that of Colles, known as reverse. So suppose if this is the proximal fragment of fracture, in case of Colles, the distal fragment goes distally. This is Colles. And in case of Smith, comes to lie ventral aspect. This is, so the two fractures are discussed in terms of the movement of the distal fragment, whether this is of course ventral. We need to check whether the distal fragment has moved posteriorly, you will call it Colles. If the distal fragment comes ventrally, that is anteriorly, you will call it. Therefore, Smith is known as reverse of Colles because the distal fragment is going opposite to the direction of the movement as we see in Colles. Then moving to injuries of lower limb. Now, patient of road traffic accident is having abduction and external rotation. The moment you have this kind of word, abduction, then external rotation, obviously there will be some mention of flexion as well. So this comes out to be Faber deformity. This is the classical Faber deformity. And in relation to hip dislocation, this suggests anterior hip. Here. So this is anterior hip Faber deformity. Okay? So anterior hip dislocation. Then Tom Smith's arthritis. Now this condition is also known as septic arthritis of infant of the hip joint. Now infancy, I think all of you must be knowing, this is less than 1 year of each child. So here there is septic arthritis of the hip in infancy, and the head of the femur is cartilaginous at that particular age, and therefore what happens, there is extensive damage to the epiphysis of the femoral head. So femoral capital epiphysis. Capital means head. Since it is primarily cartilaginous, so it's damaged by the infective process, and since at such a younger age, less than 1 year, the child is not able to communicate about the problem. So there is extensive damage to the hip joint, especially to the femoral head epiphysis. Because it is soft, it is easily damaged. So this is one of the very problematic conditions, because by the time the condition is diagnosed, already much of the damage the femoral head epiphysis occur. So this is Tom Smith arthritis or septic arthritis of hip in infancy. Then coming to TB of bone and joints, and especially this is TB of hip, which is very important from exam point of view. And once the tubercle bacilli reaches the hip joint, initially it will affect the synovium, so there will be synovitis. So the initial stage is stage of synovitis. Now what will happen if there is inflammation of the synovium? It will produce more of synovial fluid. Synovial fluid production will increase. When the synovial fluid production is increased, now the joint is limited by a capsule. So the joint will try to assume a position in which it can accommodate the excessively produced synovial fluid. And that position of hip joint is that of Faber. Here. So if the hip joint is flexed, abducted, and externally rotated, it can accommodate a little larger amount of synovial fluid. So therefore, in this synovitis stage, we will see that the affected side hip is in Faber position. So that is flexion, abduction, and external rotation. Now, what will happen when the limb is taken into that position? From a distance, when we look at the patient, we will presume as if that affected side is longer than the other side. So we will notice that there is lengthening of involved lower limb. But when we will do actual measurement, since there is no bony damage, so the actual length will be exactly the same as that of the other side. So this is just a visual finding. So we'll use the word apparent here. We'll write the word apparent because from a distance it appears to us as if the lower limb is lengthened, but actual measurement is same as that of the other side. So there is no lengthening at all. It is just a perception looking at the patient from a distance. So this is known as apparent lengthening. This is the stage 1 of TB hip where there is fiber deformity leading to apparent lengthening. And if someone asks you about bony damage, you will say there is no bony damage. So this is stage 1. The condition from here will progress to stage 2. So in stage 2, what happens? Stage 2 TB hip. Now what will happen here? The joint surface will be involved. So there will be early arthritis. Yeah, so there will be early arthritis. And once there is involvement of the joint area, there will be spasm of the surrounding muscle. So there will be spasm of surrounding muscles, and we know that hip joint is surrounded by many muscles. So the muscles which are more powerful, they will move the hip joint in the direction of their action. And the powerful muscles around the hip joint are the flexors, adductors, and internal. So these are the powerful group of muscles, and therefore the lower limb will go into a state of flexion, adduction, and internal rotation. Now, if you look at this kind of limb from a distance, you will feel as if the limb is shortened. But since there is no bony damage, and when you will do the exact measurements, they will be absolutely the same as the other side. So again, you will use the word apparent. Right? So there is apparent shortening. And why shortening is apparent is visible because of this fader deformity. After this, the patient will go into stage 3 where there will be actual bony damage. So the position of the lower limb, that is fader, it will remain as such, but since there will be a bony damage, so the length will be short as compared to the other side, and then instead of apparent shortening, you will write true short. So that is stage 3. So stage 3, posture of the lower limb is same, fader, but the only difference is in stage 2 there is apparent shortening, means it looks as if the lower limb is shorter, but the measurement is exactly the same as the normal side. But in stage 3 there will be true shortening. It means yes, finally there is some bony loss, and therefore the limb is now shorter than the normal limb. Right? So please remember that. Then moving forward, we just write it over here. In stage 3, fader attitude will continue to be there as we see in stage 2, but what will be noticed here is true shortening. This will be true. And what is the reason for true shortening? There is late arthritis stage, so it means there is actual bony. Right? So stage 1, stage 2, TB hip, very important from example. Then moving forward to very important segment from which we have questions almost every year almost in every exam, and that is bony tumors. So a fallen fragment sign. Now this is seen in which condition? The fallen fragment sign, it is seen in simple bony cyst, or also known as unicameral bony cyst. Unicameral. Right? So what happens here? A fragment of the cortex, it will break and it will sink to the floor of the cyst, and it is known as fallen fragment. Now, this condition has to be differentiated from the aneurysmal bone cyst. If I write like simple bone cyst, aneurysmal bone cyst. So one major difference between the two is size of lesion. So the size of lesion. Now in simple bone cyst, it is less than the size of the growth plate. And in aneurysmal bone cyst, it is more than the size of the growth plate. Yeah. So this is very important here. So suppose if this is the growth plate, something like this, and this is the metaphyseal region, the simple bone cyst will be something like the simple cyst or unicameral bone cyst. But in case of aneurysmal bone cyst, if this is the bone, this is the physis, the cystic area will be like this. So this is the aneurysmal, and this is of course the physis or the growth. So here we can see the size of the cyst is smaller than the size of the growth plate, and here we can see that the size of the cyst is much more bigger than the limit of the physis or the growth. Yeah. So this we need to remember. The fallen fragment sign is seen in simple bony cyst and can be seen as a fragment of the cortex lying at the floor of the cyst. Then an elderly patient presented with hypercalcemia, it means raised serum calcium, and clinical features are consistent with the diagnosis of renal insufficiency. And RBC count is severely reduced because we know that there is one hormone, that is erythropoietin, which is needed for production of RBC, that is erythropoiesis, and that comes from kidney. So if there is insufficiency of renal function, obviously erythropoietin will be less, so RBC count will be reduced. So these two points can be correlated. But what is more important in this case history is that X-ray skull is showing multiple punched out lesions. So the moment you have this kind of word, multiple punched out lesion on a skull X-ray, even if you don't know anything else in the case history, straight away you can answer it as a case of multiple myeloma, right? So multiple myeloma, obviously the patient is an elderly person. There is renal failure. Here, patient will have back pain. Then there is raised some calcium. And yes, if you do X-ray, you will see multiple punched out. Classical presentation. And as far as oncology of the bones is concerned, we call it most common primary malignant bony tumor. Yeah, most common primary malignant tumor. Because if I just skip the word primary from here, and if I say most common malignant tumor of bone, then the answer will be secondaries. It means, or what you call metastasis, means the tumor cells are coming from some other area and they are landing up in the bone. The most common malignant tumor is secondary, and if I specifically put the word primary, then answer will come out to be multiple. Please remember this. And I think we can take the opportunity to discuss most common benign. Right, most common benign, then answer will be chondroma, which is also known as exhaust. Here, this is also known as exhaust. And if I just add one word like most common primary, and then if If I write benign, then again the answer will change to osteoid here. So you see, just addition of or deletion of one word changes the entire meaning of the question statement. Anyway, so this is a classical presentation of multiple myeloma. Now, a patient presents with lower back pain, and when X-ray was done, we saw sclerotic lesions. Now, sclerotic metastasis, they usually come from carcinoma prostate. Now, this is very important because most of the metastasis to the bone is usually osteolytic. It means they damage the bone. So mostly metastasis is osteolytic. Metastasis is lytic. But in carcinoma prostate, it is osteoblastic. It is forming new bone, osteoblastic. So one very unique fact. Remember, carcinoma prostate, the skeletal metastasis will be osteoblastic, and therefore, if you do X-ray, you will see sclerotic lesions. And we know that lumbar spine is one of the commoner sites of tumor metastasis. The next question, a patient presented with knee pain and swelling. And when the biopsy was done, we saw multinucleated giant cells and mononuclear cells. Now, most likely died. Now, here, what you can understand, like multinucleated. So, suppose there is a cell and it is having multiple nuclei. So, multiple nuclei. This is multinucleated. Size is big, so we call it giant cell. So, multinucleated giant cell. And there are other cells which are mononuclear. It means they have single nucleus. These are mononuclear cells. So there is one tumor in which we have these type of cells in histology, and this tumor is actually osteoblastoma, which is also known as giant cell. And the reason why it was called as giant cell tumor, because of presence of these giant cells, multinucleated giant cells. And previously it was presumed that these are the tumor cells, and therefore this nomenclature was given. But later on it was realized that multinucleated giant cells are not the tumor cells. In fact, these are the tumor cells. Okay? So this nomenclature was given wrongly as giant cell tumor, because considering the giant cell as the tumor cells. Actually, it is not. And some people, they call it osteoclastoma, thinking it like the function has to be as that of osteoclast, so they call it osteo. So this is a classical histology of giant tumor. You will see two type of cells, mononuclear cells and multinuclear. A young boy presented with a mass in the distal femur, and X-ray shows Codman's triangle and sunray appearance. I think the moment you find this word, Codman's triangle, sunray appearance, the diagnosis should not be that difficult. It is osteosarcoma. Yeah. So, young male and around knee joint, especially distal femur, and Codman's triangle, sunray appearance, classical presentation of osteosarcoma. Now, this Codman's triangle is actually, you can say, one kind of periosteal reaction. So, the periosteum is lifted from the cortex and it creates a triangular area known as Codman's triangle. And please remember that it is non-specific. So, if you see Codman's triangle, you cannot straight away jump to the diagnosis of osteosarcoma in clinical practice. Although from MCQ point of view, you can take it in that manner. But clinically, if you see Codman's triangle, don't label it as a case of osteosarcoma. There are other possibilities where there is irritation to the periosteum. It can lead to Gottman's triangle. And yes, sunray appearance is more suggestive of osteosarcoma because there is calcification along the Sharpie fibers, or you can say blood vessels. Sharpie fibers are the fibers which connect the periosteum to the cortex. So there is calcification along those Sharpie fibers, or you can say calcification along the blood vessels given isotypic, right? So this is a classical description. Young boy, around knee joint, pain, swelling, Gottman's triangle. Then moving forward to another chapter, arthritis and related diseases. An elderly female having involvement of GIP, PIP, and first carpometacarpal joint, and there is no involvement of wrist and MCP. Now, what can be the diagnosis? See, what is involved? GIP, that is distal interphalangeal joint, PIP, right? And there is no involvement of MCP, and there is no involvement of. So, this is not involved, this is not involved. These are involved. And first CMC, that is thumb, base of thumb, first carpometacarpal. Now, this classically suggests the diagnosis of osteoarthritis. Now, why it is not rheumatoid arthritis? Because it is the most commonly affected joint in rheumatoid arthritis, right? And this is not affected in rheumatoid arthritis. Clear? So, if there is involvement of DIP, you can say it is not rheumatoid arthritis, because in rheumatoid arthritis there is no involvement of DIP. If there is no involvement of MCP, you will rule out rheumatoid arthritis because it is in fact the most common joint which is affected. Clear? So, looking at the scenario, the answer comes out to be osteoarthritis. So, if we again suppose if we have to differentiate the two conditions in terms of involvement of the joint, so what we can do, we can make a table, and that will simplify the concept, and it will help you in remembering the points for a. Suppose if we write rheumatoid arthritis here, the very first thing is we'll start from MCP joint. MCP joint is here, is not, and PIP joint can be affected in both, but in DIP joint not affected, unaffected. So this is classical. So if you see involvement of PIP, DIP, that is itself very suggestive of the case that this is a case of osteoarthritis. If there is any involvement of MCP, you will say it is a case of arthritis. So here, MCP involvement is most common. Here, PIP and DIP. Hemophilic, it involves knee, and ankylosing, it involves. Yeah. So this is how you can just reach up to diagnosis. And moving forward, female presented with pain in the knee joint, and it's about for 6 months, and then she says that it's aggravated whenever she sits after doing any household work. But on examination, like especially arthrocentesis, that is aspiration of the joint, there is needle shaped crystals which are negatively birefringent. So even if you don't know anything in the case history, needle shaped negatively birefringent crystals, this is classical of gout, right? So this is classical for gout. So needle shaped negative birefringent crystals, think of gout, and rhomboid shaped positive birefringence, think of pseudo gout. the two conditions which you need to differentiate: gout and pseudo gout. Okay, so this is pseudo. One thing now here is confusing is knee joint, because if we discuss about the joint involved, it is first metatarsophalangeal joint, that is grade 2, and this usually involves the knee joint. Then second is the substance which get deposited here. This is sodium monourate, and there is calcium pyrophosphate. And thirdly, when we do microscopy, we look at the appearance. This is needle shaped crystals which are negative birefringent, and here we'll see rhomboid shaped positive birefringent crystals. So this is in short about the difference between gout and pseudo gout. Clear? So although the word knee is slightly confusing in this question, but needle shaped crystals, negative birefringence, that's sufficient to make a diagnosis of gout. Then moving forward to some conditions, and starting with one, frozen shoulder. Now, with reference to frozen shoulder, we have to choose the correct statement, and therefore we are given with the 4 statements here, and we have to choose the right option which includes all these statements. So the one of the statement is, it is associated with diabetes. Yes, this is true. It is associated with diabetes. Then this is also known as adhesive capsulitis. Right? So frozen shoulder, it is also known as adhesive capsulitis of the shoulder joint, and patient find it's very difficult to move the shoulder joint. So that is frozen shoulder. As the name suggests, frozen shoulder. Movements are painful. This is commonly seen in diabetic patients. Very rarely it can be associated with minor trauma, and if it is related to trauma, obviously you have to rule out fractures. So A, B, C are true, and the condition is self-limiting. When I say self-limiting, it means after a course of around 8 months, it will subside by itself. So you need not do much, just give symptomatic treatment, because this condition is self-limiting, right? So here we need not do any surgery. This has not to be done. So the best answer will come out to be option B, that is 1, 2, and right? So 1 is okay, 2 is okay, 3 is okay. So this condition is self-limiting, and after a course of 18 months, the patient will be relieved of this condition. And from clinical point of view, from clinical practice point of view, now what happens, the patient will keep on changing the doctors, because he will not be getting any relief. And the moment the patient approaches around this period of time, so whatever the doctor he will be consulting, he will get the whole credit that I was suffering from this disease since last 1.5 years, and this doctor treated me. Although the condition resolved spontaneously, but the doctor will get the credit for that. So this is the beauty of frozen shoulder or adhesive capsulitis. Next question says that patient is having wrist pain. Okay, so there is wrist pain on the lateral side, and when we say lateral side, that is around the thumb. So Finkelstein test was positive. Now when we say Finkelstein test is positive, the condition is de-Quervain sinusitis. Right? So the condition is de-Quervain sinusitis. And this principally involves the tendons, the 2 tendons which forms the lateral boundary of anatomical snuff box, and this is abductor pollicis longus and extensor pollicis brevis. So this is about decurvent tenosynovitis, Finkelstein's test, where we put the thumb under the finger and we simply ulnar flex the wrist. That will cause very severe pain around the area of radial styloid process. This is decurvent tenosynovitis, and that involves the tendon sheath of the muscles tendons which forms the lateral boundary of anatomical snuff box, that is abductor pollicis longus and extensor pollicis. Right? Then painful arc syndrome. Now what happens here when the patient is performing abduction, right? Suppose this is 0 degree, and from here the patient is taking the upper arm to a 90 degree. Now what happens in the mid range, patient will have very severe pain in the shoulder area, right? So this is the mid range of abduction, and this is because of impingement of the tendon of supraspinatus muscle. So say if this range is around say you can say 30 to 60 degree, just say like that. So 0 to 30 is painless, and then 60 to 90 is also painless. So only this much area is the one when the patient is doing abduction, he will have severe pain in the shoulder joint. So that is known as painful arc syndrome, and here the pain typically comes over a certain degree of shoulder abduction, maybe 30 to 60 degree. 0 to 30 degree, no problem. 60 to 90 degree, no problem. So just because between 30 to 60 degree there is impingement of the tendon between the articular surfaces of the shoulder joint, and that creates a very severe pain during the movement. Right? So this is painful arc syndrome. Next question is about like pain, tenderness over the lateral condyle of humerus with painful dorsiflexion of the wrist. Now, lateral condyle, we know that this is common extensor origin. All the extensors of the wrist, they originate from this area. So whenever we put them to stress, whenever we do a passive dorsiflexion, so the patient is told to do dorsiflexion and we put our hand over the dorsum of the hand and we will give resistance. Now this will create stress over the point of origin of those extensor tendons, and there will be severe pain at that point over the lateral epicondyle. Right? So this particular condition is known as tennis elbow. Right? This is classical presentation of tennis elbow, which is also known as lateral epicondylitis. Lateral epicondylitis. And this particular test is known as Cosen's test. This is the Cosen's test, and golfer's elbow is known as medial epicondylitis. Medial condylitis. Clear? So tennis elbow, yes, principally it is seen in player who play tennis, but it can be seen with cricket players as well. So classical Cosen test and classically pain tenderness over the lateral condyle or epicondyle area. Now moving forward to another chapter, that is metabolic bone diseases, and here female is having genu varum deformity, and there is osteopenia. Now osteopenia. Now osteo means obviously it is bone, and penia means reduction in density actually here. So this is osteopenia, and there is pseudo fracture. I think most of you, the moment you find the word pseudo fracture, you can jump onto the diagnosis as osteomalacia. But apart from that, there are some more clues like serum calcium is less. So less serum calcium, then less vitamin D, and increased alkaline phosphorus. So serum calcium is less. So serum vitamin D is less, and serum alkaline phosphatase is high. So this is a classical picture of osteomalacia, where the entity is counterpart of rickets, which we see in childhood. So it is seen in elderly, and it is exactly the same as that of rickets of childhood. And pseudo fractures are actually the loser's zone, since they look like fracture, especially involving the neck of femur, and they are almost at 90-degree angle to the medial cortex of the neck. So this is loser's zone, also known as pseudo fractures, and this is a classical presentation of osteomalacia. The next question, 5 years boy has genu varum, and then there is low vitamin D, increased alkaline phosphatase. So again, the same picture, the only thing is that the age is now less. So this is a classical case of rickets, right? So rickets, osteomalacia, clinical picture is same, just the difference of age group. And alkaline phosphatase is high because there is increased osteoblastic activity. Next question, a 5-year-old child has knee pain, then irritability, and most important, gum bleeding. I think the moment you find the word gum bleeding, you can think of scurvy. And on X-ray, we can see thin cortex and a white line at the metaphysis. So this is a classical case of scurvy, right? So there is extreme knee pain. Gum bleeding is classical. This is pencil thin cortex, call it pencil thin cortex, and a white line. This is white line of ankle. Classical radiological features, classical history with gum bleeding. Straight away, you can say this is a case of. Now we will take certain image-based questions. Now, a 45 years old male has backache since last 20 years. So it means the condition started somewhat at the age of 25 years. So it started at the age of 25 years. Now he is having neck stiffness. The X-ray is shown. What is the likely diagnosis? Now, what we can see in this X-ray, we can see here, see, these are vertebral bodies, the cervical vertebra, and anteriorly we can see that these cervical bodies, they are fused with each other. So this is syndesmophytes. So anteriorly, the vertebral bodies been fused with each other. So this is what is the reason for neck stiffness. The patient is not able to move the neck because the cervical spine, the vertebrae, they have fused together. And this is a classical case of ankylosing spondylitis. So this is ankylosing. What does the word ankylosing means? Fusion. So here we can see the syndesmophytes, they had led to the fusion of the cervical vertebra. And the classical hints are the problem, it started in young male, and that started with backache. Right? So this is how the picture will present, and classically you can see the X-ray. And I think if you have seen X-rays of lumbar region, you might have heard of bamboo spine. So that is just because of fusion of those vertebrae, there is syndesmophytes formation. And as far as this backache is concerned, there is a classical presentation. Now, this usually comes after period of inactivity. Means when the patient will get up in the morning, he will have very severe backache, and it disappears with activity. And as the fellow is involved in day-to-day activity, the pain will go away. So that is one of the classical presentation of backache in ankylosing spondylitis. And apart from this, there can be involvement of eye. Person can have acute anterior uveitis, and the patient can present with eye, red painful eye, and treatment wise can give indomethacin or backache, right? So it has very good effect, and eventually there is a fusion of the vertebral bodies. So we tell the fellow to do physiotherapy, chest physiotherapy, because that is what we can do. Otherwise, there is no specific treatment for this condition. So the answer is ankylosing spondylitis. The next question, elderly patient came with a history of fall in bathroom, and then he was managed conservatively by plaster of Paris, and then he presented late with this deformity. So what you can see here, if you see something like this, it looks like a classical dinner fork deformity, right? So the classical dinner fork deformity, and the moment you find the word dinner fork deformity, the injury which comes to your mind, I think it will be Colles fracture. The Colles fracture, and if we define the Colles fracture, it is extra articular fracture at the corticocancellous junction, right? So it is extra articular fracture. Then second point is, so cancellous junction. And third, what is very specific for defining the displacement which is responsible for this deformity is that the distal fragment has displaced dorsally, means posteriorly. That is very important. Distal fragment has displaced. Yeah, so this is the typical description for fracture Colles. So it is an extra articular fracture, means it is not involving the joint, and there is dorsal displacement of the fragment, because volar displacement is for Smith fracture. Don't volar displacement, because that will go in favor of fracture. Fractured area is same for both. This extra articular corticocancellous junction, but the point which differentiates the two entities, the Colles and the Smith, is what is the direction of the displacement, the distal. If it goes backward, straight away you can go and answer it as Colles. If it is going anteriorly or ventrally or volarly, you can answer it as Smith's. Right? And therefore, as I already told you, since it is going exactly opposite to that of Colles, so we will call it reverse Colles. The next is, a young lady is having pain in small joints of the hand, and this is classically associated with morning stiffness, and the deformity is shown here. Now what you can appreciate here, you can see swelling, see the swelling, and this area is actually the metacarpophalangeal. This is the area of metacarpophalangeal joint. And what else you can notice here, you can see a deformity which is coming out into the fingers. So we'll take the words one by one. So one of the important clue is young female. This is one important clue. Then morning stiffness, means when she will get up in the morning, you'll find it very hard to move the fingers. And third, it is involving small joints of the hand. And here, classically, we can see there is swelling of the MCP joint, that is the carpophalangeal joint. And if you remember, I told you, like in rheumatoid arthritis, MCP joints are the most commonly involved. So the moment you see involvement of MCP joint in a young female, straight away you can go and you can mark it as a case of rheumatoid arthritis. Okay. Now, here in rheumatoid arthritis, you need to remember two deformities which can be seen. One is the fan neck deformity, One is the swan neck deformity. Another is junior, what we call buttonholing. Now, these deformities, they are differentiated based on the attitude of the proximal interphalangeal joint and the distal interphalangeal joint. So what we'll do, we'll write PIP and we will write here. Now, what is happening in swan neck deformity? The PIP is and the DIP is clear. And in routine deformity, the PIP is flexed and the DIP is. So you can see the deformities are almost reverse of each other. So if we look into this particular clinical picture, now let us see what is happening here, because this area is PIP and this area is DIP. So what we can appreciate, there is extension or hyperextension at PIP and there is hyperflexion at PIP. So taking these two terms together, here this is extension, this is flexion, and this goes in favor of swan neck deformity. PIP is extended and DIP is flexed. So this is swan neck deformity, and the opposite will be boutonniere deformity. So these are two commonly asked deformities whenever we are discussing a case of rheumatoid arthritis: swan neck and boutonniere deformity. In this clinical picture, it is classically, you can see here, extended, flexed. Moving forward, then a patient has a painless palpable bony mass near the metaphysis of a long bone, and we have done the X-ray. What is the diagnosis? Now, what we can see here, now just look at one important picture. This, you see this white line, this is actually fused growth plate. This is the fused growth plate. So this fellow has just crossed the age of, you can say, 18 years. Now the growth plate has already fused. Secondly, we can see there is a bony growth, something like this. So this is the bony growth. Clear? And this is known as exostosis or osteochondroma. And it is usually painless, a bony mass, and related to metaphysis. So this is classical for osteochondroma, which is also known as exostosis. And there are few points which you should know for this entity. Number one, the tumor will grow in size till there is growth at the physis. It means in this particular case where the growth plate has fused, now the tumor will not grow. So the tumor will keep on increasing in the size till around the age of 16 to 18 years, till the time period when the physis is active, and that is increasing the length of the. So after this phase, tumor should not grow normally. But if it continues to grow beyond this point, you can think of malignant conversion, because this entity is usually benign. And if you remember, in one of the points I told you, most common benign tumor of bone is osteochondroma. So this is usually benign, but if it continues to grow in size beyond the period of skeletal maturity, you should suspect now there is malignant conversion to chondrosarcoma. This is one point. Another point is that when we take X-ray, we see that the tumor is of a certain size. But when we open it during surgery, we find the size of the tumor to be much more than what we have appreciated on the X-ray. Now, why? Because if suppose this is the size of the bony component of the tumor, which is evident on the X-ray, but when we operate, it is covered by a cartilaginous cap. So therefore, with naked eye, the size of the tumor is much more than what we have appreciated on the X-ray, because in the X-ray we only appreciate the bony component, and the cartilaginous component of the tumor is not visible on the X-ray. Therefore, the size of the actual tumor is much more than what has been seen on X-ray, right? So this is in short about osteo. Then moving forward, old lady has back pain, and in elderly females presenting with back pain, if you take X-ray, you can see codfish vertebra. You can think of osteoporosis, very common condition to see in old females, especially post-menopausal state, because we know that there is no estrogen, so there is a decrease in the bone density. So this is osteoporosis. The next question, young female is having pain around the knee joint, and the X-ray was done. Now, which is a true statement for the condition shown in the X-ray? Now, what we can see here, number one, this tumor is originating somewhere around the epiphysis, and then it is migrating towards the metaphysis. Metaphysis, number one. And number two, this tumor is more onto one side. You can say it is more onto the lateral side, and medially there is no extension. So it is eccentric. So two E's we can write here. One is physial. The second E we can write here, it is eccentric, means to one side. So the moment you find these two E's, you can think of giant L, right? And in a much more nice case, you can easily see the soap bubble appearance. So you can see soap bubble appearance as well in X-rays. So the moment you find this epiphyseal, eccentric, and classically, if you can document the soap bubble appearance, it is very easy for you to label it as a case of giant cell tumor or osteoclastoma. So option A is absolutely right. It is arising from epiphysis extending towards metaphysis. It is eccentric. We can easily see it is more towards the lateral side, and the lesion has distinct clear-cut margin. Yes, we can clearly say that this is the extent of the tumor. Classically say that the tumor is well demarcated, and for giant cell tumor, the treatment is always surgical. Depending on the case, we will decide the surgery. So there is no role of chemotherapy. In fact, there is no need of chemotherapy in giant cell tumor. So D is the answer here. The next question, male had his injury to leg 2 years back. Now he is having pain and deformity of the leg, and then X-ray of the leg is given. Now here, if you look at the X-ray, there is a past history of injury. Now, what is missing from this case history is that there might be some fracture, because looking at the X-ray, we can see two things here. One is classically we can see the sequestrum. Second is we can see the involucrum. Now, sequestrum is a dead piece of bone which is lying within the infected granulation tissue. This black shadow is all the infected granulation tissue, and within that, the dense white area is all sequestrum. So this is sequestrum. And this is sequestrum here, right? And sequestrum is actually a dead piece of bone is lying within the infected granulation tissue. So this is a dead piece of. Now what happens whenever a portion of the bone dies? Body tries to produce new bone. So involucrum is the new sclerotic bone which surrounds the sequestrum. So here if you see, this white bone is all involucrum, right? So this dense white bone is all involucrum, and it tries to give strength to the area which is weakened because of the development of sequestrum. So the two classical points here, sequestrum and involucrum, and these 2 points are sufficient enough to make a diagnosis of chronic osteomyelitis. Right, so this, we can say, this is a case of chronic osteomyelitis of proximal tibia, and which usually follows open fracture most commonly. And in some cases, if there was a closed fracture but it was operated, and without taking the proper sterile techniques, it can land up in infection as well. Right, so there are two possibilities of getting chronic osteomyelitis. Either there is open fracture, in which there is already more possibility of having infection. Sometimes if the case is operated without taking due sterile care, then there are chances of reducing the infection in the area. Now, next question is about a person falling on the ground, landing over thumb, and the X-ray is shown. Which fracture is this? Now, here we can see this is first carpal, second, third. So, in first metacarpal, this is the base, okay, base, and we can see there is a fracture involving the base of first metacarpal, and it is involving the articular surface, right? So because it is articulating with the carpal bones, so it is involving the articular area. So this is obviously an intra-articular fracture. Intra-articular fracture involving base of first metacarpal, and this is Bennett's. Yeah, this is Bennett's fracture dislocation, and the fragment is usually displaced because of the pull of abductor pollicis longus. Yeah. So this is classical Bennett's fracture, intra-articular fracture base of first metacarpal, and should not be confused with Rolando's fracture, where there is extra articular extension, there is comminution, giving rise to the appearance of either T or Y configuration to the fracture line. Yeah. So here the fracture line is almost linear, but in case of Bennett's, in case of Rolando's, it will be somewhat like either Y or sometimes like T. Yeah. So this is how we differentiate the two fractures occurring in this area, that is the base of first metacarpal. So Bennett's, there is a linear fracture line extending into the joint, and for Rolando's, this much description is same, is intra-articular fracture base of first metacarpal, much is same, but in addition to this, there is extra-articular extension. There is extra-articular extension, and as a result of this, sometimes you find, sometimes there might be a mention of comminution, and as a result of this, the fracture configuration is either Y or shaped fracture line. Please remember this much. Bennett's and Rolando's involving the same area, but the fracture configuration is different. Next question, identify the fracture which is being discussed here. So you can see this is humerus, ulna, this is radius, this is medial condyle, this lateral. So we can see a fracture which is involving lateral condyle. So this is fracture lateral condyle, and this is fixed with open reduction internal fixation using K wires. Right? So ORIF has been done. Because you see, there is so much of, see, this is actually the articular surface, and it should be brought and aligned with this area, then only it will heal. Otherwise, it will never heal. Right? So we can see here has been used has been proposed nicely, and therefore we see that we always say that uh, open reduction has to be done because we want to maintain articular congruity. Right? This is very important here, and this is classical fracture lateral condyle of humerus. This has been discussed. Now, moving forward to the last question of the series, and we have to identify the fracture and we have to classify it as per the Salter and Harris classification for the physical injuries in children. So, what we can see here, this is femur, this, yeah, and we can classically see physis growth plate. Right? So we can see here. Now, what is happening here? There is a, this is obviously metaphysis of lower end of femur, and we can see that there is a fracture line which is going through the metaphysis and it is reaching up to the growth plate or the physis. So here the fracture line is running through the physis and it is extending up to the, so such type of fractures as per Salter Harris are classified in type 2, and this fragment is known as Thurston-Holland sign. Yeah, so this metaphyseal fragment is known as Thurston-Holland sign. So this is a classical type 2 Salter Harris injury, right? So this is enough for this session. I'm very sure you might have enjoyed the session.